Canfell, who is a paediatric dietitian from Queensland with experience of working as a clinician researcher. And he's currently a research fellow in digital health, where he's combining that expertise in dietetics, digital health, to address issues of precision approaches to the management and prevention of obesity. And he's going to talk to us today about precision approaches to improving obesity and prevention in Queensland, Australia. Thanks.
Thank you, Amy. And thank you all for coming this afternoon. It's an absolute pleasure, and I have received nothing but the warmest of welcomes from you all. I arrived yesterday in Cambridge, but I've been in the UK for a few weeks now, so I have no symptoms of jet lag left, and feeling fresh and ready to go. So thank you for joining. Today I'm going to talk a bit about this word precision, and I had a meeting with Esther earlier today, and we were debating a little bit about the word precision and what it exactly means. So hopefully I can address that in the context of obesity. So I'm from Brisbane, Queensland. Hands up who's been to Australia? Yes, oh, lots. Keep it up if you've been to Brisbane. Okay, more than I expected. Brisbane, this is our lovely University of Queensland campus, which on the bottom sort of backed onto the cityscape, and in spring, which is now all across the city, blooms these beautiful jacaranda trees, which these purple flowers. And it's such a significant event that the university has a bloom festival just around these jacaranda trees. The size of Brisbane is about the equivalent to a quarter of London in population size, and about the same size as Paris. Queensland is a very large geographical state. You can fit 2 UKs in Queensland geographically, which gives us large variation between metropolitan and regional areas. So even though it's me presenting today, I'd like to really acknowledge our research team and collaborators, mentors, across various organisations, and this work wouldn't have been possible without them. And that's a photo of our digital health PhD cohort at a conference earlier this year. We were dubbed the Purple Brigade because we all wore purple university colours to the conference. Very coordinated fashion. So today I'll talk for about 40 minutes and give some time for questions and discussion at the end, and let you get off to your 3 p.m. meetings. But I'll give an overview of our Queensland Digital Health Centre to start before going into a research overview. And I'll present 2 research programs today. This invitation, I think, was sent out to MRC, Epi Unit, as well as the This Institute. So as part of my fellowship, I've led 2 programs of research, one in digital transformation of healthcare, which is acute care based and focused around healthcare improvement, and one in this topic of precision public health, which is this nascent emerging area, a bit elusive, and how that's being applied to obesity in Queensland, before talking about the challenges we've had with that and the future research direction. So the presentation is quite interactive. If you see a QR code, feel free to pull your phone out and it gives you just more information on what's on the slide. But this is our centre in Queensland, and it's a very new centre. When I first started, we had 3 researchers in the Faculty of Medicine and Digital Health, and we now have over 40. And our lead, Associate Professor Claire Sullivan, has, as well as the broader team, everyone together has leveraged about £20 million in funding in those 3 years to establish this centre. And our focus is the quadruple aim of healthcare. So improving healthcare outcomes, clinician experience, patient experience, or reducing costs. And we're very transdisciplinary. I'm lucky to sit and work with pharmacists and nurses and data scientists daily, very similar to here. And that's really, digital health is now pervasive in almost every field. And this is what we're striving towards, a learning health system where all data entered during an episode of care is reused in a continuous cycle of learning to benefit future consumers. And data is the foundation of that, and digital infrastructure is the foundation of that. And really, this is what we're aiming to achieve. And I'll start to bring in this word precision a little bit, and I'm sure this pyramid is familiar to most of you, but this is the health impact pyramid, and we can see on the bottom socioeconomic factors as the area of increasing population impact, and as you move up the pyramid, it's increasing individualization of care with less population impact. The question we've tried to ask is, can we direct interventions of policy with greater precision at each level of the pyramid to more effectively close health gaps? So this is the research overview, and the broad theme has been, I was very fortunate in my fellowship, I was given a free rein, and really in my position description it said, just research the digital transformation of healthcare. And I thought, oh my gosh, that's so broad, what am I going to do? So tackled two approaches, and I'll talk today about digital hospitals and how we've tried to answer this question: what is the impact of digitizing hospitals on the patient and clinician experience of care? And the second question, how we can use electronic medical record data to improve how we monitor, survey, and direct interventions for obesity at scale. And I'll talk about two use case projects from each program, some of which are finished, some of which are ongoing, to give you a flavour of those programs. So this first program in digital hospitals, to start with the Australian context, in Queensland specifically, digital hospitals are now service 70% of public healthcare. So we are rapidly maturing in this space. We have government agencies, we have independent fellowship agencies in digital health, and national industry research body in digital health. And we've really seen the national focus on investment in personal health records to enable consumers to access their own individual health information at any point in time and across any healthcare provider. These are the problems that we've identified that we're trying to solve with our research. It's been really difficult to measure the value of digital hospitals and the digitization of care as this really changes over time and place. And transforming digital healthcare is really unpredictable and messy and complex and disruptive. Measuring that disruption has proved challenging. And the impact of that digitization on care experience has been more difficult to measure. Typically, these big investments in digital hospitals and EMRs have been made out of a business case focused on cash value or cashable return on investment. But it's quite a narrow view compared to the opportunity for it to impact the experience. So this is a study that we recently completed on what is the impact of digital hospitals on the clinician and patient experience. And we did a systematic review and a synthesis of qualitative studies using AI. So we identified mixed method studies investigating this question, and extracted from the qualitative studies all of the qualitative data, and using a machine learning content analysis tool, we, analyzed the qualitative data to answer our question. And we define experience as any one of these synonyms, really: satisfaction, attitude, perception. There's lots of ways to describe and define it. And we use this tool, LexiMensa, to drive the AI content analysis of the qualitative free text data. LexiMensa is a tool that was developed at the university. It uses machine learning to extract the most prevalent concepts in text and display how they're connected visually, which is of huge benefit to really large qualitative free text data sets that typically take many, many hours and weeks and months to do traditional manual analysis. This is the output from LexiMensa. This is a sort of a heat map, and I'll explain what the colors mean and the sizes, but the big bubbles are themes, and they're generated from the smaller bubbles, which are concepts. And the concepts are discovered using machine learning from the text, and their interconnectivity is shown visually. So we can see the red bubbles, or the warmer colors, have a higher higher strength, if you like, of the theme in the text. And the cooler bubbles have a lower strength. And you can see from this that it's quite difficult to interpret what this actually means. And so there's always a qualitative research insight and analysis that's needed. But this just draws from participant quotes in our qualitative studies and shows that this concept of patient is very closely linked to documentation and time, paper, and then more closely to care. And what we can do is look really granularly then at the quotes that are supporting these concepts and themes, and see how they're interrelated. What we found was that most studies, we found 61 studies, and most of them had focused on the clinician experience. So there was very few and not enough evidence for us to draw conclusions on the impact of digital hospitals on the patient experience. And this sort of idea of experience appeared really positive in simple quantitative measures. How satisfied are you with a digital hospital versus the qualitative data that revealed more substantive tensions. So this way our overall findings mapped to the clinician and patient experience and how digital hospitals affect things. And I'll just draw your attention to probably two key points. The first, that overall satisfaction with digital hospital seemed positive. But then on the negative side, there was some consistency with how it's affected the clinician-patient interaction and how digitization mediates that relationship, potentially in a negative way. And so looking for solutions to help that relationship build. So then we thought, well, then let's actually look at what's happening on the ground in real time. How is this digitization affecting care? And so we did this study, which sought to move us from this concept of work as imagined, and lots of evaluations of digital hospitals survey clinicians 6 months to a couple of years after they're implemented. And so you're getting this retrospective idea of what the transition was like. And we wanted to move to an understanding of work is done. How is this digitization impacting workflows in real time? So we completed an ethnographic study at a brand new digital public hospital in Queensland, about the 10th of the size of Addenbrooke. I found out it was an 1,100 bed hospital, which just the size and scale of that is very different to Brisbane. And we observed clinicians in real time performing routine clinical activities and made observations about what was happening, how they were using digital systems, and what it meant for clinical care, patient safety and quality. And that was all qualitative data, and we used Leximancer again to analyze that qualitative data with machine learning. So we performed our clinical ethnography sort of in the following 2 months after the go live, when services transitioned from a purely paper-based hospital to a completely digital system. We conducted 38 unique observation events and observed 55 individual clinicians across almost 100 patient interactions and 58 hours of observations. And this was our Leximancer output. So you can see the strongest theme here is notes and how clinicians are, what their practice is for clinical note taking and how that's connected to our electronic medical record. But also a concept in here of paper, as well as movable sort of EMRs on wheels. WOWs are called workstations on wheels. They used to be called computers on wheels, but if you do the acronym, it's not the greatest acronym. And it's just more us people did that. Yes, and so I'll interpret this map for you. And really what we saw was differences across each discipline on how they used the digital system. So allied health had a really dynamic and practical workflow that blended paper and digital workflows together. Nursing was focused heavily on use of the systems for patient safety purposes pharmacy had heavy interaction with data to validate their medication dosages and administration. And the medical team transitioned very smoothly, and they maintained the efficiency of their team-based workflows on wards. Importantly, in our observations, what we saw, there was no observed harm due to the digital transition. And really, we saw this blending of digital and paper workflows together to achieve this threshold of trust to make a clinical decision. Clinicians weren't entirely ready to let go of their paper workflows. That was still their prerogative and something they use significantly. And we still, the enormous gap really is the patient experience. We saw that reflected in the systematic review, how this digitization can potentially transform experience as well. So thank you to the public health people for bearing with me through the acute care research program. I'll talk now about our second program, which has been the focus of my research fellowship with the University of Queensland, and this idea of precision public health. The Australian context of obesity is similar to the UK. We have 2 in 3 adults and 1 in 4 children live with overweight and obesity. And there's new modelling in Queensland that suggests that children born this year, our current generation or next generation, could have a reduced life expectancy of up to 4 years due to obesity. And in response, Australia has launched this national obesity strategy just very recently, which may be of interest to accelerate national progress. And there's a variety of strategies and enablers and so on. And each state in Australia is responsible for implementing part of that plan. These are some of the problems that we've had that we're trying to address with this program. I was telling a few people this morning, we have a problem with data. Our nationally representative data on health and disease are collected via surveys. The most notable being the National Health Survey, and that's collected every 5 years as a cross-sectional sample. And then once it's collected, it takes the Australian Institute of Health and Welfare roughly 2 years to analyse and release that data. So once it's in the hands of very excited public health professionals and researchers, it's up to 7 years old. And that data is being used to fund, to make investment decisions, to design interventions and policy, and it's potentially out of date. Monitoring and surveillance of the determinants of obesity, we all know they're across social, environmental, commercial, political factors, is fragmented and siloed because those systems are disconnected. And we have more data than ever, but translating that data into action is difficult, and we can collect and monitor and analyze, but that pathway from data to action is less clear. And digital health has been a key enabler for us in addressing some of these problems. Using big data and digital infrastructure, we can start to improve the contemporaneity of this data that is informing large-scale obesity policy and practice, and leverage it to rebalance what is the traditional treat-manage model of healthcare, which the UK and Australia does very well, but is ultimately unsustainable, with a more consumer-centred predict-prevent model of healthcare. And this is a concept of what measured matters. And there's this theory or idea that because we can count and measure treatment and management much more easily than we can prevention, it's therefore more fundable and I guess matters more in very heavy inverted quotes. So who's seen The Emperor's New Groove? Recognize Cusco? Yes, Nita, hand up. Yeah, that's right. So I talked a bit about the learning health system before. What about a learning public health system, where the same concept is applied to determinants of disease, where every data, lots of different types of data are entered and used in continuous cycles to learn success in prevention in people and communities. And this is this is what that learning public health system looks like in practice, this idea of precision public health. And I put this photo up there because this concept of precision public health is fairly new. It's emerged in the past maybe 7 to 8 years, quite rapidly, but with its academic skeptics. And I'll talk a little bit about, there was a paper that was written called Precision Public Health, the Emperor's New Clothes, ? Is it just redressing public health concept that we've always done? And I'll talk a bit about that. But first I'll make fun of the word precision. And this is I have to acknowledge Miriam Curie for the inspiration for this slide, who's the director of the Office of Precision Public Health at the US CDC. And really, what is a precision pool? Like, how is that different to a pool? We can still swim in it, I'm sure. How is precision agriculture different from just agriculture? We see this word precision now everywhere, but it's not very defined. What it essentially means is just that next generation, modernization of something that we've been doing for so long, but can be advanced in a really fast way with new technology and new data that enables greater levels of granularity and contemporaneity to improve precision and how we might target interventions. What actually is it? Well, there's the definition that's been proposed, and really this precise targeting of one or more biological, social, behavioral, environmental characteristics of an individual within a population applied at scale. And there's various terminologies for this, what precision public health is, and some of them are more informatics focused on surveillance and monitoring, and that's the foundation to precision public health interventions and policy that are built upon really strong surveillance infrastructures. So I'll talk through a brief anthology of the field, just how it's emerged and how it's evolving over time. It first was born out of the precision medicine initiative that was launched by Barack Obama. Who remembers that? Back in 2016, I think. Some nods, some hands. And Miriam Curie, the director of the CDC office, applied those same concepts to a population level, and that's where this term was coined. Then it advanced into the field of genomics, and genomics is the primary use case of how we could advance precision initiatives to improve population health. Then came the academic backlash, and lots of discourse in very prominent academic journals, Lancet, the BMJ, arguing against and for this term precision public health. Then 2020 happened, and we saw the extreme value of data and monitoring, surveillance, prediction at a population level to precisely target public health efforts to reduce infection rates of COVID-19, to predict where outbreaks might happen, and to, in a really agile, adaptive way, respond quickly to areas with greater precision. The concept has really advanced strongly for infectious disease and communicable disease. But we're just starting to see how it might be applied, the concepts, to chronic disease, non-communicable disease prevention. And there's a group at Harvard Population Medicine who are really leading this work strongly. And more discourse recently about the idea of the data as the foundation to precision public health. And finally, a roadmap towards how we might achieve this for chronic disease. How could it really help in a specific way? It can help us to access measured health data in what is typically self-reported surveys. It can reduce the time between when we can collect that data and when it can be used for decision-making. Improve the targeting of interventions at key time points over time, place, and person. And help us to monitor the impact of new interventions with the same infrastructure, the same data that told us where to target them. And this is the idea of real-world data as the foundation of precision public health. This is characterized as data that's organic. It's routinely collected, it's typically automated, and the purpose is repurposed for public health purposes. So social media, its purpose is connection, but can be repurposed to inform public health decisions. The same with electronic medical records. This is some examples of real-world data in action. And on the left is an example from genomics. We have here genome-wide polygenic risk scores for obesity that leverage individual genomic information to predict with very good accuracy future risk of obesity. This is the example from the Harvard Population Group that draws real-time electronic medical record data to develop a new surveillance and monitoring tool for the highest burden chronic diseases in the state of Massachusetts. There's information there for type 2 diabetes, smoking, hypertension, obesity, and you can stratify that data by health service area, perform time series analyses, and track groups of patients' movements through care pathways. See how valuable that could be for public health policy and planning. And this one is I won't say my favorite, but it really excites me. These are satellite images from space. And this group have mapped the obesogenic environment and overlaid it with obesity prevalence to show hotspots of where prevalence is highest and the obesogenic environment is at its most intense, to apply those learnings at a state level. And these are two examples of what precision public health looks like in practice. And the first one, newborn screening, is one of the oldest programs of this type in the world. In the USA, that screens millions of newborns every year for genetic conditions that can have early intervention and identifies about 15,000 of those every year eligible for early intervention. And this is a program in Queensland, actually in Australia, that's really consumer screening of risk factors for chronic disease. You can go online and completely calculate it yourself. And then if you so choose, you can be referred to a community health program, which currently has 19,000 participants and has culturally tailored advice as well. So this leads to the research gap, how we can use this real world data to guide public health practitioner decisions to improve health weight in Queensland. And this was what my fellowship has mostly addressed. And the aim for this was to leverage electronic medical records as a use case of real world data to develop an interactive dashboard that can show rates of healthy weight, overweight, and obesity in digital health services in the public healthcare system in Queensland. And these were our methods, and it could not have been done without the very strong partnership between academia, health promotion agency, healthcare, and with industry. And the biggest challenge with this work has been, and the biggest success as well, generating the inter-organisation trust rapport that has allowed for the first time in Queensland researchers to have a streamlined way to access electronic medical record data from the health system. This was something that previously has taken years for researchers to access requests, and we've built new infrastructures to help do this. I'll step through each of these in the coming slides, but this is our primary end user partner, Health and Wellbeing Queensland, the state government health promotion agency, very similar to the Office for Health Improvement and Disparities. And their entire remit is chronic disease prevention, specifically obesity prevention. I was lucky enough to start with them when they started in 2019 as we had a team of 4, and there's now a team of 50 strong who are working on programs in Queensland to advance obesity prevention, especially in remote food security is a big issue for us, and integrating prevention activities into routine clinical practice as another arm. This was our first step. We really wanted to see how this real world data was being used globally to advance chronic disease monitoring and surveillance. And we found 6 examples that had developed tools to monitor up to 28 chronic diseases, leveraging all different types of data and aggregating them together to get a fuller picture of the determinants and prevalence of these diseases. What we found is the studies had developed these beautiful dashboards and monitoring tools, but the evidence of translating that new information into decision-making, into new practice was unclear. So then we thought, well, we need a bit of a roadmap as to how to do this, or a potential roadmap as to how to do this. And I approached the team at Harvard Population Medicine who'd developed that lovely RiskScape tool. And we developed together a roadmap of how to do this for chronic diseases. And we came up with this 3 horizons framework for precision public health chronic disease. That took lessons and learnings from acute care digital transformation of health and applied them to a population level. And Horizon 1 is the foundation. We have our building our data infrastructure, gathering the digital workflows together, aggregating them. An example of that might be establishing an electronic medical record or a disease registry. In Horizon 2, we can start to take the data back out. And that's sort of been one of the biggest challenges, how we can then apply analytics to the data to generate new information and new insight. And those analytics have slowly moved in the past 10 years from very descriptive to more predictive, and in the future, more prescriptive analytics. And we can use that new information to design precision public health interventions and policies, and then wraps around in the continuous cycle of learning. So then we thought, oh, well, let's map all of the available data that we can that's usable for this precision public health of obesity and evaluate its availability and quality. And we found 38 primary data sources of obesity. And after evaluating the quality of that data, we saw that electronic medical records were the only source with excellent quality, but were currently unused in practice for obesity. We developed this map, or had this map of the determinants of health relevant for obesity prevention. And then in our data set, I'll just explain what this map is showing. The evidence map of all of the data sources for obesity relevant for prevention in Queensland. And each data set is coloured according to the determinant of obesity that they cover. And on the y-axis here, we have contemporaneity, so how often that data set is updated. And on the x-axis here, we have size, sample size. And you can see the clustering of data, of evidence, data sources towards the bottom left, where they have relatively low contemporaneity and relatively low sample size. And up in the top right-hand corner is the electronic medical record that covers, has data, covers every determinant of obesity, is the largest and is the most quickly updated. Then we thought, well, we better try and get that data. And so this was a project, the Smart Hub, that was led by our director, Claire Sullivan, with that really strong partnership with healthcare that developed a new mechanism for researchers to streamline their access to electronic medical record data in a safe, ethical, and trusted way. And this Smart Hub is a new platform for researchers to request data from the EMR to do their own research. This isn't the healthy weight dashboard. I'll get to that in a little bit. Once we had that system and infrastructure in place, and our data custodian approvals and governance approvals, which took a very long time, and we're still getting one more. It's taken 2.5 years. But we engaged in a participatory co-design process with our end users, with the Health Promotion Agency, to co-design how this dashboard might look in practice, engaging multidisciplinary end users across a requirements phase and a design phase. And this is what we developed, the Healthy Weight Dashboard, which for Queensland is a new way to monitor healthy weight in digital health services across Queensland over time and place. It can monitor healthy weight, overweight and obesity in up to 1 million patients in digital hospitals, stratify by variables, age, gender, year, facility, geographic area, and show hotspots of overweight and obesity to help more granular understanding of the burden. Very importantly, all of this data is de-identified and aggregated, and the data never leaves the health system. So it remains protected by the firewall, and that was part of the health system requirements. So I'll talk quickly through what the dashboard looks like, and this is just mock data. There's no patient data shown, but this is the home page, and you can see a snapshot of in the state with these digital hospitals, the total rates and percentages of healthy weight, overweight, and obesity, stratifiable by health service, gender, facility, which is more granular than health service, year, age group across the life course, and suburb. This is the ability of the interactive heat map for a user to drill down and identify hotspots, if you like, in this case, green spots of healthy weight percentages, areas that are doing really well, that have a high percentage of healthy weight in their service, which we can potentially learn from. Another capability is this time series analysis. So we took some learnings from the Riskgate group in Massachusetts to monitor trends over time based on health service or based by facility, depending on how you want to stratify. But this gives us the ability, or our end users the ability, to identify which health services are performing well, which health services might need more targeted intervention and need to engage with to improve rates of healthy weight. So how could this be used in practice? And our end user Health and Wellbeing Queensland has told us that really these three core areas, and there are many more, but I'll just talk about these three. How this data could help to answer questions that haven't been answered yet in Queensland. We don't know the rate measurement of child growth, for example. We don't know how often these children are having their height and weight measured. And understanding that information can help us to guide clinical education programs that can improve measurement of weight. Supporting place-based intervention and highlighting success for areas of doing well. And the next phase is leveraging this data to answer new research questions. This project was to set up the infrastructure and the operational pathways to do this. And the research requests that come through the Smart Hub is the next phase to really drill down into the data and ask new epidemiological questions. We know that EMR data is not population representative, so it represents an ultimately acutely unwell population, and in Queensland is biased against rural regions, but we know that's where the disease burden is highest. In Queensland, we've had digital transformation of care, but it's been focused on metropolitan areas to start with. And that's advanced quickly, but there's a gap remaining in this data chasm in areas with the highest burden. And the priority there needs to be transforming those rural areas so they're on an equal playing field with the metropolitan areas. Our future research priorities, just coming back to the digital hospitals program that I talked about first, is we want to leverage AI to transform how free text PREMs, patient-reported experience measures, are being analysed in health services. There are two core questions. How did you, what was your overall experience of care and how could it be improved? Patient-centered free text responses to, and we want to scale up and really make that workflow highly efficient with this tool, LexiMancer. Validating the BMI rates in the dashboard with the nationally representative samples to see if what we're seeing is representative of the population. Fill some of those missing data gaps where there are digital gaps with community profiles and different types of real world data. And looking at the feasibility of how this end user organization could use the dashboard in practice. How would it fit into their workflows? How could it digitize public health workflows, and what the impact might be? So I'll end there. That was about 40 minutes, and just acknowledge our funding from the Australian government and university, as well as the State Health Promotion Agency and Queensland government, and just say thank you very much for your time today. I know an hour is a very long time to take out of your days, and I'm very appreciative, and I'd love to learn more about you and your research programs. I'm in Cambridge until Friday, and if you'd like to connect, this QR code opens an email message to connect. It even fills in the subject header for you. It's super nerdy. I didn't even know if it would work, but I promise you it works, and it's not a scam. So yeah, so yes, thank you very much for your time, and I'll leave it there for questions.
So much, Oliver, for a thought-provoking talk, and great to see that you really embrace the tech in every aspect of your life.
Yeah.
So did anybody have any questions for Oliver?
We have a couple online, Amy.
Okay. Should we start with Nita and then come online?
Yeah, sure. Oliver, that was tremendous. Really great. A beautiful slide.
Oh,
And very digital.
yeah, very digital.
So, very digital in the future. What I picked up in your project 3 and 4 and so on is about the descriptive, to get to know the data on percent of healthy weight,
Yes.
overweight, obese, etc. That is still observing to get the precision, if you will, of where are the hotspots, where are we achieving. But on the intervention side and what can be done about it, is there what's happening in the precision, public health or precision space
Yes.
for that? And where I'm also going with this is, for example, in the hospital electronic records, as well as recording patient characteristics, is there any move towards their health behaviors being captured and that sort of thing, like their dietary physical activity?
Great questions. Thank you for asking them. Yes, the first one. So I'm really glad you asked that. I'm part of a scoping review team with the USA. We're doing precision public health interventions. So there hasn't really been a synthesized evidence base yet on the impact of PPH interventions. And so the field itself has been really focused on that horizon 1 and 2. So leveraging the new big data sources of data infrastructure, building them, aggregating them together, and then applying those descriptive analytics. So it's still really emerging. And we still don't know how those analytics are being applied to generate new interventions and what the impact of those are. So I'm hoping that that review will provide us a first foundation of data into the impact of those interventions. To answer your second question, yes, the answer is yes. So we have, this data is just pulled from structured data fields in the EMR, but there's a lot of richness we haven't captured yet in pre-text in the clinical notes. And tools like our Leximancer tool could help us to understand that data at scale. And that the future plans really are, now that we've set up the infrastructure, we can start to look for more variables, start to integrate different sources of data together. So the answer is yes. It's in there, we're just getting there.
But do you see it as a vehicle for collecting the information that exists, even when it comes to behaviors, as we're talking about, or also as a vehicle for conveying, collecting, enabling new information, but then ultimately also intervention space through the digital?
Yes, absolutely. I think it could be end to end. It could be a continuous loop. We're just seeing it come one way at the moment, but you're right, it could go back the other way in some of those learnings, and that's when you start to get towards that prescription, really, what we're seeing and how that could be applied to the health service level for maybe X health service there's XYZ recommendations to improve this value that they have. Yes, that's a great idea.
So Mohammed's question up first, which was, wasn't sure what it means to be a digital hospital.
Yes.
And how that differs from a non-digital hospital, whether you could clarify
Yes.
that clear distinction in Australia.
Yes, great question. We define a digital hospital very simply, just one that has a full stack terminology, electronic medical record that's across the entire health service. Some hospitals in Australia have basic electronic medical records that might serve as tools to deposit paper records, for example, but we are looking for one that's used across the entire continuum of care in a hospital and has things like clinical decision support integrated. So there's criteria for how mature a digital hospital electronic medical record can be, from 1 to 7, and we define it sort of at level 6 or above. And how they're different to non-digital hospitals? Yes, so pretty much they're really the paper-based hospitals that are still operating purely on paper records.
In your qualitative work, you talked about how people were sort of blending the paper and the digital.
Yes.
And you can see that as a sort of blending, but could you also see that as a resistance? That there's just some things that people just prefer to do on paper, and that they are resisting that sort of digitalization of it. Whether you've explored why that is, or can that be overcome? Should it be overcome?
Yes, I mean, we saw that the paper workflows were really personal. We saw so individual clinicians would have their own personal ward sheet or notebook that they used to record data, to make later, to make a clinical decision, to record notes. Some clinicians used it because the digital system was a barrier to building rapport with patients. And that was particularly evident for social workers we saw. So that's a really good question. I think would be next step is why maybe it is resistance and safety. Maybe it's reaching that threshold for making a clinical decision. Not sure.
Yeah. And then Jean's got a couple of questions online. So the first question is, we often say information is necessary but not sufficient to support public behaviour change. Is that relevant in terms of providing data to public health practitioners? So we're providing them with data. I presume the question is, what else do we need to be doing with that? Giving them data to monitor things maybe not involved.
Yes. Yes, I'll do my best to answer that. Is this relevant in terms of providing data? I think so. I think, especially in Queensland and Australia, really the data that's being provided to public health practitioners now is from those really old surveys. And so perhaps, that data is just one piece of a decision-making puzzle. We have the lived experiences of the community, of the public health practitioners, evidence, which is informed from data. But I don't think it's the be-all and end-all. I think there's new ways that we can transform the types of data that we use to inform decisions, but it's certainly just one cornerstone of a decision at the end of the day.
Thank you. Thank you so much for the very informative presentation. So I'm very interested in, because I'm a PhD student doing social media interventions for healthy eating in young people. I realized you mentioned something about social media, but didn't get the chance to, really explain that. I was just wondering, so for example, for a scoping review, I saw in the figure you mentioned about social media, but it's mostly for community. So what did you find about social media, and what do you see is the potential in the research area of social media for public health?
Yes, thank you for that question. The social media example we found in that scoping review was a platform called Social Info Buttons, which integrated social media data together with other health care data to understand population health behaviours. and what sort of environments that population were being exposed to. So I can send you that paper if you like, but that I can't remember the exact details. But just as another example in how we're using social media to understand behaviours and experience, part of a study that's explored the impact of or how people perceive telehealth appointments and using Twitter as the avenue to mine experiences about telehealth appointments during, during and post the pandemic. And that's generated some really cool insights into that other platforms may not have been able to do. People generally tend to go on Twitter to maybe post positive or negative experiences. We found mostly negative, but it's just another source. Yeah.
Great talk, Oliver. Enjoyed it very much. A question about your ethnographics. It's about the timing of when you did it.
Yes.
Because digital transformation isn't a date, it's a process.
Mm-hmm.
And I think if you'd done that type of study here, or if you'd done it around the time when you went digital, you would have seen a lot of hybrid, bit electronic, bit paper.
Mm-hmm.
But that then, changes with time. And if you'd asked the patients what they think, probably initially might have been a little bit negative because the doctors and the clinicians are all looking at the screen rather than them.
Yeah.
But then later on, you get things like my chart, where the digital transformation really changes the person's experience because they can access their own records. So you seem to have done it quite early, I guess.
Yes, you're right. We wanted to capture it really early because the research around that early period had all been done retrospectively, so a year or two later. But we hadn't seen an example where someone was in that really messy period observing what's happening in real time. But you're absolutely right in that the experience of digital healthcare changes over time, and it's that initial period of disruption where there's often negativity, often things like high staff turnover and burnout and so on. But then that peters out, and in some of the digital transformation research, they've asked a really simple question. What do you think of digital hospital? And they say, oh, it's terrible. Like I don't like it. It's messing up all my workflows. And then they're asked, would you go back to paper? And they say, oh, no, no, wouldn't go back to paper. So there's that dissonance, that tension still.
I mean, it's the magnitude of that is huge. So here there were people who could not count us, even when we went digital doing a clinic, without still having access to the paper.
Yeah.
Then a few years on, people say, what paper?
Yeah, yeah, exactly.
I mean, and it's huge. It's not a small transition, it's massive.
Yes, you're right.
So healthcare has a marginal impact on health, and most healthcare is either informal or out with the hospital. So I'm interested and slightly sceptical about the impact of digital hospitals on population health. So my question is, what's the state in Australia at the moment for primary care electronic medical records in terms of the interoperability, the communication with the hospital, and the communication with environmental experts, population health experts, and so on? Because when I was last discussing this with people, it wasn't good, but I think it's been rapidly improving, is my impression. But it'd be good to hear from someone who knows.
Yes, we've thought about that a lot and explored that option a lot, and it hasn't been feasible. You're right, it's improving, but in pockets.
Yeah.
There's pockets of optimism and new ways, partnerships with individual primary health networks, which are Australia-wide, to improve access to data for research. But for example, in Queensland, it's less advanced, and that integration between primary care and secondary care and hospitals just hasn't happened. And there's new technologies like FHIR to try and move that along, and OMOP, which is a common data model to map data together, but that's still in the testing phase.
And it's problematic because people can skip from one GP to another in Australia. And
yes.
They go to the GP that gives them the metformin, the morphine for their migraine, and they leave the GP that won't give them morphine
Yeah,
So it makes it difficult, whereas we've got the population denominators in primary care. I think it
that's right.
slightly easier. I think you're ahead of us in population health, you're ahead of us in hospitals, and about 25 years behind in
Yeah.
primary care records.
Yes, I've had exactly the same thought, and all of our primary care, most of our primary care practices are on electronic medical records.
Yeah.
One of two, medical director or best practice, but they're privatized data sets.
Yeah.
So it's up to the individual practice and the provider if they are willing to share that. So.
I've had a question online that has popped up on that chat, but wondering if patients opt in or out of the use of their data.
Yes, it's my understanding it's an opt-out. So we have in Queensland the Public Health Act, which sort of governs the use of healthcare data in Queensland, that allows for secondary use of routinely collected data for the public good. And so that was part of our long conversations with the data custodians in the health system, the public health unit, how we could do this in a way that adhered to those regulations in a safe and ethical way.
So I think that brings us right on time. So thank you very much, Oliver, for your talk. As you said, he is around for the next day or so. People who want to talk more, and thank you all for your time.